image.
The first photograph shows right hand with flexion of the MCB joint and extension of the BIB and DIB, feature of intrinsic plus hand. The second photograph shows left hand with wrist flexion, MCB joint hyperextension, flexion of the BIB and DIB joint, features of intrinsic minus hand.
What is the underlying pathology?
The deformity is produced by imbalance between intrinsic and extrinsic muscles of the hand. If the extrinsic muscles are weakened or paralyzed, the spastic intrinsic muscles, metacarpophalangeal joints, flexion and extension of the interphalangeal joints, cause of this CVA, cerebral palsy, brain injury. If the intrinsic muscles are weakened or paralyzed, there is an opposed pull of the normal long extensors, so lead to hyperextension of the metacarpophalangeal joint, while the long flexors flexion of the BI lead to flexion of the BIB and DIB joints. Intrinsic minus causes combined median and ulnar nerve palsy, brachial plexus injuries, Volkmann ischemic contracture, compartment syndrome of the hand, leprosy, neurological such as Charcot-Marie tooth, polio, amyotrophic lateral sclerosis.
How would you differentiate clinically between the two conditions?
The banal test allows differentiation between the intrinsic and extrinsic tightness. The test involves passive flexion of the BIB joint when the MCB joint is either flexed or extended. The test considered positive if there is less flexion of the interphalangeal joint when the MCB joint is extended than when it is flexed. This occurs as metacarpophalangeal joint extension stretches the intrinsic muscles, extensor force of the interphalangeal joint, which prevent flexion. Banal Lister test for intrinsic tightness. Metacarpophalangeal joint held in a slight flexion while examiner move phalangeal interphalangeal joint into flexion. If cannot flex, intrinsic or joint capsule tightness. Place the MCB joint in a few degrees of flexion to relax the intrinsic. If joint can now flex, then it is the intrinsic tightness. If when MCB joint placed in a flexion still cannot flex the BIB, then it is joint capsule tightness or contracture.
How would you differentiate between median and ulnar nerves lesions in the hand?
The appearance of the two signs is almost the same, but the lesion represented depends on what you are asking the patient to do. In median nerve lesion, if you ask patient to make a fist, the index and middle finger cannot flex. Thus the hand of benediction. When you ask the patient to extend the finger, the index and middle finger cannot fully extend due to loss of radial lumbricals. In ulnar nerve, due to ulnar damage, the third and fourth lumbricals are unable to extend the BIB and DIB joint at the fourth and fifth digits.
How can you differentiate between the intact FDS and FDP of the middle finger?
Of the middle finger, you fix the index and ring finger and ask patient to flex the middle finger. There will be flexion of the BIB and DIB should be floppy. As the examine the FDB, you fix the middle phalanx of the finger and ask the patient to flex the finger. If a flexion of the DIB occur, mean intact FDB.